Hello, everyone, and thank you for joining our 6th annual Conservative Scoliosis CME, performed virtually for better or for worse, obviously, this year. We see attendees trickling in. We have a really big group today, and I'll just give another minute for everyone to join. But thank you. We are up over 100 people right now with almost 300 registered, so that's astounding and really speaks for the appetite for improving in this space of conservative scoliosis care. I want to thank the all-star faculty that is taking the time to put together talks and doing this today, including my partner, Ben Roy, Dr. Jim Sanders, who's been a huge part of the CME and more broadly of leadership and innovation in conservative scoliosis care for his whole career. So thank you very much, Jim, for taking the time to do this. I want to thank our two incredible Schroth therapists, Prachi and Kelly, who are so great in taking the very best care of our kids and teaching us how to do better as well. And Amy, another great therapist who we work with quite a bit closely. So thanks for joining us, Amy. And then Jim Wynn and John Tunney, two great orthotists, John at my place and Jim sort of down the street, for lending your perspective. I will kick off just by letting you know that Dr. Jim Sanders will moderate this session, but rather than making him come back and introduce me, I will share my screen and get into my talk entitled Cure AIS. Okay, and we're almost there, everyone. Okay, and again, thank you for joining our 6th annual CME on non-operative treatment of scoliosis. As you know, because you're here tonight spending your time, and as you'll hear from this passionate group of faculty, there is so much opportunity to do better in this space. We are going to have a great discussion today. It's broken up into 3 different groups. There'll be an opportunity for question and answer, so please send those in to the moderator in this session, Jim Sanders, or to all the panelists. And again, thank you for joining. Here are my disclosures. The most relevant part of my disclosure is I'm talking about ways to take better care of patients with scoliosis, and I am a scoliosis doctor, and we have a Center for Conservative Scoliosis Treatment, and we use Schroth physical therapy and Rigo Cheneau bracing that I am a proponent of and we'll talk about today. The bottom line here is that I think you all agree, we have a significant opportunity to improve the care, the non-operative care, as well as the operative care of children with adolescent idiopathic scoliosis. There's tremendous variability in practice, and we've done some work demonstrating that, and that implies that some people are doing a better job than other people. There's been a recent resurgence in the conservative treatment of adolescent scoliosis, driven by a better understanding of pathophysiology, the BRACE study, and increased understanding and dissemination of what Stu Weinstein and Lori Dolan taught us with that study. The Schroth philosophy and the passion of physical therapists in making care better in this space. And finally, the passion of patient-centric groups. And this is one of the areas where you see the groundswell driving care in a positive direction. The Curvy Girls is probably the best example of that type of patient-focused, patient-centric advocate. We spent quite a bit of time quantifying this variability in non-operative care. This was an SRS grant that is in publication right now. And what we did is we sampled 23 surgeons from around the United States. Ross, I don't know if someone else is driving my slides, but it seems to be advancing. And we looked at issues in brace wear, vitamin D, scoliosis, PT. And we asked the question, why is there so much variability? This points to the lack of rigorous evidence, to cultural biases, to patient preferences, and the financial and logistical realities that some places don't have a great Schroth therapist or an incredible Rigo Cheneau orthotist down the street. But again, this means that at least some patients are getting suboptimal care. Variability means variability is bad in medicine. Brace taught us a lot. And braced was a randomized trial that showed significantly higher rates of success in patients who are braced. It also showed that the time in brace matters. And this really led to having brace monitors be a standard of care in this space. You should be able to look at your patient's brace monitor and talk to them intelligently about how they've done, because there's clear dose response effects for kids in braces. And while this graph may not pertain to every age, every size curve, and every severity, more time in brace means less progression and less surgery, and that's our goal. So if we look at variability across the United States, we see significant variability in US surgeons around brace wear and significant variability around brace compliance. And this is one such compliance monitor. We're now using a different monitor, and you may hear from East Coast about a new monitor that's in development that allows wireless Bluetooth feedback to the patient and their family and the surgeon and the orthotist. We're really excited to launch this next generation of so-called smart braces with East Coast. What else did we learn from this randomized clinical trial? We learned that in-brace correction matters. So the more frontal plane correction, the less chance of surgery for any Cobb angle and for any maturity. This tells you that you need to be getting an in-brace x-ray. Since that time, our group and others have done some interesting work showing that it's not just the in-brace frontal correction, but also the in-brace sagittal or lateral parameters and the in-brace axial parameters that matter. And in research that we're presenting at IMAST and SRS, we are able to show that the in-brace axial correction, the extent to which you derotate the spine in the brace as measured by EOS images, correlates with their progression in surgery. So this is a brave new world, and we need to be paying a lot more attention to three-dimensional analysis of in-brace x-rays than we're doing. And a lot of times this doesn't happen. This is a kid that saw me last year for a second opinion about their brace. They never had an in-brace x-ray, and the kid's curve out of the brace and in the brace was exactly the same. The brace was ill-fitting and obviously not doing anything. And you can't blame the patient or blame bracing as being ineffective here. This is a failure of appropriate multidisciplinary care and a failure of thoughtfulness about the importance of in-brace x-rays. Unfortunately, we see a lot of variability, and a lot of people are not measuring these things, as our survey showed. The type of brace probably matters quite a bit, there are a lot of type of braces. You'll hear about this more from John, and a lot of it has to do with regional bias and who you trained with. But I think we do know some things, and there's been some great finite element analysis by Stefan Perrant and Carl Eric Albin showing that if you model a brace three-dimensionally, certain variables over and over seem to be important. The location of the opening, the strap positioning, trochanteric extension, and most importantly, asymmetrical design in three dimensions. That's why you're hearing a lot more about three-dimensional or asymmetrical braces right now. Rigaud-Chenot braces have a philosophy of asymmetry with large cutouts with an aim at improving three-dimensional design. And when Rigaud and Chenot started making this brace, they didn't have the tools that we have available today, like EOS imaging, to obtain three-dimensional analysis in the brace, but their principles ring true. And again, it's been shown that these type of braces have larger frontal plane correction and lower chances of correction or surgery. And this is Paul Sponseller's work. And other studies have shown that the three-dimensional in brace correction is also important. Yet there's a lot of variation in brace wear, as you see, and we need to fix this. What else can we talk about? There's huge variation in when to wean, and that's really not right. And a lot of people are weaning at RISR 4, and Lori Carroll and her group showed that the chance of curve progression is high even at RISR 4. Moreover, we should never be talking about RISRs, and Jim Sanders has taught us this, that RISR will mislead you about 25% of the time because digital hand scoring and RISR do not correlate. And RISR will often tell you to come out of a brace too early. So you should be using that. And this does not happen for a lot of people. In this survey, about 67% of people did not use Sanders staging to drive their care. And hopefully this is better than it was done 2 years ago. What about scoliosis-specific physical therapy? Well, you hear about this from the experts, but the principles here involving stretching the concave tissues, strengthening convex muscles, and relieving asymmetrical end plate stress, which is the basic principle of Porter-Volkmann. And I know you'll hear more about that from Dr. Sanders. This is the same thing that we do when you have a contracture of your elbow. You stretch the concave muscles and strengthen the convex muscles. This is a patient compliance tool. I am trying to show that kids who do Schrock physical therapy are also going to be more compliant with bracing, and that data is forthcoming. It's a way of empowerment. And there's been at least 4 randomized trials in the area of Schrock physical therapy showing a reasonable but statistically significant and clinically significant effects. This is one such study, which is a double-blind study showing 8 degrees difference in 1 year in kids who were braced. And again, this is a double-blind randomized clinical trial. Compliance is admittedly a problem, we see even in patients in our group who we think are very motivated, only a minority are still compliant with Schrock physical therapy at 1 year. And this is a challenge and something we need to work on. But you see, among the kids who are compliant and among the kids who are not compliant, about 6 degrees difference in curve progression at 1 year. And this is our rationale for looking at compliance of therapy the way we look at compliance in bracing. And we need to do better at this too. You see lots of variation in scoliosis-specific physical therapy and prescriptions for that, and that means some patients are not getting the right treatment. What about vitamin D? And I'll finish. Replicated 2 studies that have not been replicated in the last 2 or 3 years that seem to show that in a randomized trial, kids getting vitamin D had lower chances of progression. Here you see the here you see the rates of progression in the vitamin D group, 16% versus placebo, 48%. But again, this has not been replicated, and we're awaiting more work in this area. Still, I give vitamin D and calcium to every patient because, in my view, there's really no downside. And there's lots of variability in this space as well, with many physicians in this area not routinely prescribing. I think it's fairly clear we can do better. There's a lot of variability in this space. Some patients are clearly getting suboptimal care. There's tremendous opportunity for research, and we really need to standardize and optimize care. And we have best practice guidelines now that we've worked on that have been published, and more work is going out in this space driven by SOSORT, POSNA, and SRS. So thank you very much. I will leave it here and pass the podium back to Jim Sanders, who really needs no introduction. He is an absolute leader in this space. He's taught us all so much about conservative scoliosis care, and he's going to speak to you today about how can we make non-surgical care more powerful. Thanks very much, Jim.
Well, thank you, Mike. Because I was concerned about the internet connection here, it's pre-recorded, so you're going to see me sitting here without my lips moving while we run this through to try to keep it working well.
I'm going to take you through a series of questions which are very testable and, if answered well, can help us to treat scoliosis non-operatively in a very powerful fashion. Some facts are very clear about scoliosis progression. First, we know that it is tightly coupled to the growth spurt. This has been shown by the work of Duval-Balpère in France, and we've shown the work in our own research. There also appears to be a strong threshold effect in scoliosis. Curves less than 20 degrees at the beginning of the growth spurt or 30 degrees at the peak are unlikely to progress to a surgical range, while curves greater than that are highly likely to progress to a surgical range. Scoliosis progression is curve pattern dependent, with thoracic curves progressing more than lumbar curves, but lumbar curves progressing later. It's also possibly etiology independent during the growth spurt, as scoliosis of all of these different etiologies rapidly progresses during the adolescent growth spurt if it hits that threshold. We also know that it's amenable to external forces being applied which can change the course of the disorder. This was shown clearly through the BRACED study. So I'm going to take you through the concepts of what's needed to advance effective non-surgical care. This is going to involve straightening of the spine, but it's also going to involve other aspects, not just equalizing the forces, although I think that that's probably the major factor. So the first question is, why does the growth spurt make scoliosis worsen? There are several traditional considerations of how scoliosis forms and progresses that have really not borne out over time. The first is this concept of anterior spine overgrowth. The work of René Castellan in the Netherlands has really disputed this, and is pretty strong evidence that this is not occurring in scoliosis. The second is an imbalance between intramembranous and enchondral ossification, and I'm not really even sure what that means. As we start thinking through scoliosis and why it worsens so rapidly during the growth spurt, I think the fundamental realization is that all musculoskeletal tissues grow in response to the growth plate. The growth plate makes the bones longer. This applies the signals then to muscles, tendons, ligaments, nerves, and even blood vessels that they need to grow. And it's this stimulus that's occurring from the growth plate that makes all of the other tissues grow. This happens quite rapidly during the growth spurt, much of which is secondary to the spine. It's also clear that if nerves are injured, they will adversely affect muscle growth. It will also affect limb growth. This is seen in children who have cerebral palsy or who have spina bifida, or in nerve injury of other type in young children. The first real model of scoliosis progression came from Ian Stokes, who developed this concept of the vicious cycle. Initially, a spine starts out with some curvature, and that creates asymmetric loading because of gravity. Because of the Hütter-Volkmann principle applying pressure on the growth plates, this leads to increased pressure on the concavity of the curve, and concave compression causes growth slowdown, which creates asymmetric growth, which creates further wedging, which creates this cycle where the curve continues to get worse. It does not account for the initial spinal curvature. So for Ian's model to be effective, you have to have some etiology which creates an initial curve, and then it's his biomechanical model which continues to create the progression. So the Stokes model is very appealing, but ultimately it's a very simple model and probably too simplistic for us to understand and correct scoliosis. In my understanding, what happens is that you have your curve, which is initiated through whatever the etiology is. The muscles on the concavity become shortened, those on the convexity become lengthened. At some point then, the nucleus pulposus shifts toward the convexity. It's only at this point that the stresses become unequal across the end plate. The nucleus itself is principally liquid, and based upon Pascal's principle, the stresses within any segment of a liquid are equal throughout that liquid. Therefore, it equalizes the stresses throughout the end plates. It's only once it becomes eccentric that it allows compression to occur on the concavity and tension to occur on the convexity. And at that point, the Hütter-Volkmann principle can take over and allow the scoliosis to worsen because of increased wedging occurring within the bone. At some stage, the convex muscles are no longer able to restore normal posture. Once this is happening, then the scoliosis will continue to progress. There's also evidence out of Hong Kong that patients who have decreased bone density do have increased curve progression, and so that could also contribute to wedging at this time. For us to treat scoliosis effectively, we have to define whether this model is correct, and then begin to apply it to correct the curve over time. So this leads to our second question, which is which of these tissues are actually limiting the correction? It could be the muscle, the joints, or really the ligaments around the joints, or the annulus fibrosus. Each of these have specific properties, and we need to identify this. There's lots of possibility that advanced imaging may be able to help us. Of these structures, muscle is by far the largest of them, and therefore it's the most powerful if guilty. But it also gives us a very good target if indeed that is the case. There's a lot of interesting recent work on contractures, and we tend to think of contractures as occurring just in the joint, or in the spine. It could be from the facet joints or from the annulus fibrosus. But it's very clear that contractures are not just from positioning or muscle imbalance. Some really nice work that's being done by Roger Cornwall looking at brachial plexus palsy has found that if you have postganglionic denervation, you're going to get poor muscle growth. And muscle growth, as they have identified it, occurs by two separate mechanisms. The first is a fusion of muscle stem cells, these satellite cells,
to create these multinucleated myofibers, and that's the most common method. But you can also get protein synthesis within the myofibers, which allows them to elongate and create muscle growth by this. In Cornwell's model, when you have an injury to the brachial plexus, it disrupts the normal formation of sarcomeres within muscle. What happens is that you get increased protein degradation and some increase in protein synthesis. And this leads to overstretched sarcomeres, which are too short, and you have impaired longitudinal muscle growth because of this, leading to a contracture. If you give them a proteasome inhibitor, on the other hand, you balance out this further in the direction of increased protein synthesis, which restores the ability of muscles to grow and eliminates the contracture. If this mechanism is occurring within scoliosis, it does give us a chance to treat scoliosis medically, and I think we need to look into this quite carefully.
Question 3 is, how do we take advantage of viscoelasticity and remodeling? Are viscoelastic, meaning that they can deform further over time. The two basic ones being creep, where you apply a force and you see it stretch over time, or you apply a stretch and you see the forces dissipate over time. This is what allows us to use halo gravity traction, which is really the only place that we use viscoelastic properties currently for scoliosis treatment. If we're going to do this, we need to know what's the right direction. Do we need to stretch coronally, sagittally, rotationally, or via traction? We also don't know how much is enough. We need to study the time constants of the various tissues that are involved. This could use very rigorous research. We need good biomechanical models to look at the direction. We need to have bending MRIs or other studies to help us identify that. We need some good animal models to look at the tissues. But this gives me a lot of enthusiasm for dynamic bracing, where stretches could be applied over time with variable amounts and in various directions. It may also give us some really good insights of what might happen with physical therapy and how we could make that more effective. Biomechanically, I believe that our goal should be to even out the stresses on the end plates by making the discs horizontal. If this is true, then it really emphasizes why brace correction is so important and is likely a factor in why the dose of bracing matters. The longer the nucleus pulposus is centered in the middle, the more likely the stresses are going to be equal throughout the time and give less growth inhibition and help to correct the curve. If this is true, it also implies that night bracing is not likely to be effective for most patients because gravity is such a major force. So clearly it's not just the concave muscles which are contracted, but we have to figure out how we can deal with the convex muscles which are no longer restoring the spinal balance. Bracing can't restore the muscle function, and so really only active exercises that can do this. What we don't know is, can patients selectively activate these muscles? And if it's proprioception, can we train the body to be understanding of where it is positioned in space? Question number 5. How can we win this battle with compliance? Bracing is not popular with kids. In the TSRH study, 27% of the children being braced wore their brace less than 2 hours a day, and only 31% wore it more than 10 hours a day. Laurie Carroll has shown that if you do use compliance monitors and use it for counseling, you can increase compliance, which can be very helpful, but it doesn't solve it all. Can we make exercises such that they're fun, automated, and easier? Can we incorporate them into other activities that they want to do? Adolescence poses its own challenges. It's hard enough having good compliance in cooperative adults, much less in a child who's going through so many things as they are going through adolescence. Can we actually create a science of childhood brace and exercise compliance? It's clear from the brace study that higher compliance has better results, but we desperately need to be able to deal with the psychology and social determinants of scoliosis perception and treatment if we're actually going to beat this disorder. It's clear that social media can change scoliosis care, and Curvy Girls has done a good job with this. However, this only reaches a certain segment of patients with scoliosis. It doesn't reach boys, it doesn't reach those who are socially isolated or those who have other etiologies of scoliosis. I'm very excited about the possibility of creating smart braces that tell us not just if a brace is being worn, but whether we can make it better. It could change colors, perhaps, or could it apply the viscoelastic stresses that we discussed and correct curves over time? Can it identify where the brace is likely to be uncomfortable, change that, change the pressure that it's applying throughout the day, and actually identify why kids aren't wearing it and help us to identify those issues and solve them? So where are we now? Scoliosis surgery really does not require a huge understanding of scoliosis, but if we're going to be effective treating scoliosis non-operatively, we need to understand it very deeply. I think this is an exciting time for spinal deformity research and look forward to contributing with you. Thank you.
Well, so with that, I'm going to turn it back over to Mike Vitale. And Mike, as he's indicated, is been doing this now for 6 years. This is a wonderful course that I'm very privileged to be part of. And Mike, I think, has really taken a wonderful leadership role in helping to promote the thinking that's going through care for children in a non-operative fashion. Mike?
Sorry, just catching up a second over here. Thanks very much, Jim. I really appreciate it. Okay, thank you very much, Jim. I'm going to share my screen and we will change gears just a little bit. I loved your talk, Jim. So much interesting information there. Okay, the next talk is a little bit different. It's a talk that has to do a little bit about the balance between innovation and patient success. And here I'm going to bring up a few examples, not only in the area of vertebral body tethering, which we'll get to, but in scoliosis care in general. A lot of this stems from work that Jim and I and POSNA and SRS have done with the FDA. I do have significant conflicts here. I was involved in the design of the tether, so that's important to know. The FDA has controlling innovation and the balance of safety for all medical devices, drugs, radiation, cosmetics, and food. Think about the enormity of this task. We were on a conference call with them. They've approved 600 new things in the last month alone related to COVID. The average device costs the industry about $20 million and 6 years to get through the FDA process. So they are certainly looking out for patient safety. For pediatric devices, $20 million is too much. The markets are small, the financial incentives are weak, there are liability concerns, and this has resulted in an unmet need for new child-specific medical devices. So what do? Physicians are trying to do the best that we can. So we use adult devices, even if they're too long. And here you see someone cutting a screw on the back table of the operating room that they're inserting into a vertebral body. Designed for other purposes. On the right side of your screen, you see vertebral staples, which were originally developed for foot surgery. It's probably no surprise that they didn't work that well and are no longer used. That's not the right way to do it. But although physician-directed use or off-label use is not ideal, sometimes we have no options. And the FDA acknowledges that there's an ethical obligation to do the best that we can do. The FDA does not regulate clinical use, only marketing. And again, we've done lots of work with the FDA. Again, I was on a conference call with them earlier in the week about some things. I think they're a great partner, but they are also living this challenge of balancing patient safety with appropriate innovation. The other thing I want to talk about is the so-called bandwagon effect, which is what happens when something becomes popular too quickly because charismatic mavens become evangelical about it. And we've all seen this over and over and over in so many areas of medicine. The problem is this: at the beginning, almost all treatments good, and this sort of hypothetical relationship between time and results. If you don't study something long enough, it appears that the early results are always good, although we know over time they often turn bad. And there are some people out there who are so enthusiastic about the new thing that they jump from early results to early results to early results. Sometimes these thought leaders are trying to do the best that should be done, but they're really delivering outcomes at the bottom of the results curve. And this is what we need to be cautious of. Some examples: electrical stimulation for scoliosis. There were some early studies that showed a 72% success rate when we applied electrical stimulation to patients overnight. It took a number of years before well-done studies and then subsequently a meta-analysis of those studies showed absolutely no effect of electrical stimulation in the treatment of idiopathic scoliosis. It's been abandoned. Cupping. This is a patient that saw me and subsequently had to see a plastic surgeon because of marks left by their non-operative provider. And again, it's hard to imagine how someone thinks this is really helping the kid. The spine cord brace, unfortunately, is another example. And early on, there was so much enthusiasm about this. 8 publications that seemed to show good, favorable results. Unfortunately, all with the original inventors of the device. Subsequent studies included a randomized trial showed significantly higher curve progression in the spine core versus traditional braces. And this is rarely, if ever, done anymore. Well, what about stapling? Again, a number of early mavens, including Randy Betts, opened our eyes to the possibility of growth modulation, and very early studies showed 80% success in curves less than 35 degrees. I would ask you, what's the success rate of non-operative treatment in that group? Nevertheless, this was done quite a bit, and a number of studies were subsequently done, culminating with a study that we did that showed 5-year minimum outcomes, because I did a lot of stapling, and looking back on it, probably shouldn't. We had about 40% of the kids that we stapled at our place that had a posterior spinal instrumentation infusion by 5 years. And this has largely been abandoned. So where are we with vertebral body tethering? Well, early studies showed proof of concept, including this kid who had a dramatic improvement in their curve. And subsequent studies by Sendani et al., who is a great reporter, a very honest scientist, showed interesting early results, first in 11 patients and then in 32 patients. But again, look at how early the follow-up is here, 1 year. Remember that graph I showed you. Other studies continued to show pretty good results. And then Peter Newton most recently showed about a 40% revision rates for vertebral body tethering at 2 years. And here you see a kid was overcorrected, a number of the kids needed fusion. And again, these studies with adequate follow-up and well-done studies are critically important. Now we are studying all the vertebral body patients, either in the pediatric spine study group, which I help run, or the harm study group, which Peter Newton helps run. And this is going to be the way that we make care better. And I think we're going to do better than this 40% revision rates once we better understand who the right patients are, when to intervene. But we're not quite there yet. In some, there have only been 5 published papers in 67 patients, about 200 patients overall, with 8 unpublished papers, and a lot more coming out of this space, folks. But about that curve and think about where we are. I think tethering is here to stay. I don't think the results will be the upside down U, but they will not be the 85% great results that maybe are initially reported in the first 6 months. The FDA has now approved a tether, which means we can study it, and data is starting to really accumulate. I think if you're talking with your patients, you need a process. This is a handout that Amber created showing benefits and disadvantages of one option versus the other. I probably will tether 1 patient out of every 10 or 15 patients that we do a fusion on. And again, you need to engage the patient, get them to exert their preferences, tell them that there's a much higher rate of revision in tethering, but there are some potential advantages. Be careful, you already see people innovating too quickly, doing posterior tethers. This has been done, tried, and failed, and some interesting anterior lumbar double tether designs as well. So be careful of too rapid innovation. In summary, don't be first, don't be last. Be careful of the bandwagon. Don't resist the urge to always do better, because we can do pretty good things in the traditional place and the care of our patients, but we need to be judicious and really think about indications and engage the patient transparently and honestly about what we know so far. Thank you very much. I will stop sharing and turn the podium back over to Jim.
Michael, thank you. Let's see. I can't start the video, so you're just going to have to go without seeing me here for some reason. So Michael, I think it's a crucial question for everyone who is trying to treat spinal deformity. This is an area that, because we don't have perfect answers yet, people want to try something new. And so the incentive to try something like tethering or stapling or electrical stimulation is there. We don't have good animal models like in other disorders. And how do we get beyond that? And what should our standards be in your thought process to do this ethically and to avoid problems for patients? Because the only way we're going to figure out scoliosis right now is on humans.
Yeah, and that's the problem. There is a balance between innovation and, to some extent, experimentation, and in patient care. In areas where we have good treatments that we know deliver reliably, predictably good results, I think we need to be careful about innovation. Classic example there is total hip replacement, where we've had great prostheses for a long time, and for a number of reasons, not always driven by the needs of the patient, small innovations resulted in less good results than the results that were originally done. Metal on metal hip-bearing prostheses are an example. The total disc replacement for lumbar back pain is another example of tried and failed techniques. In the area of adolescent idiopathic scoliosis care, we have good treatments, but imperfect treatments. We need to get better about knowing when to do what to. We had a great talk by Dr. Dubussé this morning, in fact, in our grand rounds. Amazing. He still gives an incredible talk. And he spoke about how gross we are in our ability to customize care. That if we were able to look at three-dimensional rotation instead of just being focused on a 25-degree curve, we'd better understand who needs a brace and who will do well on a brace. So we're still early in our infancy, and we need to balance innovation with protecting patients, especially when there's good ways to take care of patients. Jim, let me ask you a question. Tell us what, as a maven in this field, what are your personal best practices when you see a 13-year-old patient, for example, Sanders 3 with a 35-degree curve? What do you do with regard to bracing, PT, and vitamin D?
So I think that the best evidence right now is still for bracing and for vitamin D and for physical therapy. The reality is we don't know what the best correction is. Ideally, I think we have some good philosophic things, and that we're trying to even out the end plates and try to get the discs such that they are horizontal. My preference is for a derotation brace, and I am strongly against nighttime bracing, because I think that if you truly want to be effective with this, a nighttime brace to me becomes a terrible compromise, but sometimes it's about the only thing that you can do based upon where the child is, the psychology of the family, all of the things that are surrounding them. I do get the children involved with the therapy. We have a lot of children who come from a very long distance, and I find that to be a bit of a challenge. The Schroth therapy is very good for the children who live very close by. The SEAS method is probably better for our children who come from a long ways off, because it's less therapist intensive. They can have some periodic checkups with the therapist. But therapy, in my mind right now, is at a point that it's based upon people's thoughts, and we need to study it in much more detail and get some better evidence. I do use the vitamin D. I think the studies from Hong Kong are quite good. Clearly, it's hard for them to follow up on it with all the events that have happened in Hong Kong in this recent time. So I'm very much a proponent of those. But every time you're seeing a child and a family, they're in different circumstances. And everything that we do has to fit around the circumstances of that child, what their resources are, and it's not just the physical resources, it's also the emotional resources, their distances to care, et cetera. We have to work through all of those.
Great.
Mike, there's a question in here from anonymous attendee said, how would you recommend a physical therapist have a discussion with an orthopedist that is still using RISR about using the standard score instead?
Yeah, I think it's a good question, and there's a sensitivity to approach. And, I just think too many studies now have been done, both studies that you've done, Jim, that have validated the use of digital scoring, and then studies that have been replicated. Ben Roy, my partner, led another study looking at variability in RISR scores, and also and then also a study that was validated by Jack Flynn and the CHOP group, looking at correlation between the two scores. And there is correlation, but it's relatively low at the extremes, meaning there are certainly patients who look like they're near done growing by RISR who have significant growth remaining. And that's a problem, because that could lead you to say, I don't need to brace this kid, or I need to stop bracing in a kid. And in that kid, particularly with a larger curve, I think you're running a higher chance of having that kid go to surgery. So in my view, and there was pretty good consensus, as you know, in the best practice guideline that we worked on together in this space, I really don't think there's any role for RISR in the modern day care of kids with scoliosis. How would you approach it? You know, I think it depends on your relationship with that physician. You could, you know, send them some of the literature. I'm well aware that many of us sometimes are resistant to change. It's true that it does involve, in most cases, a separate X-ray, although Jack Flynn and some have gotten EOS X-rays in this position. It's not perfectly replicable with regard to looking at digital staging. Jim, I'd be curious if you're getting your X-rays, your hand X-rays in this position as part of an EOS, or if you're getting a separate dedicated hand X-ray.
Well, when I was in Rochester, we ended up doing them separately because our radiologist expected it. I've moved down to North Carolina, and part of my going down there was we were getting an EOS, and it has not been installed yet. So at this point, they are still very separate from this. We have several questions about alternative therapy modalities. And Mike, do you want to tackle those real briefly? Yoga or myofascial release?
And also,
yeah, I mean, you know, thank you. I had a friend who's a triathlete who got a myofascial release treatment recently, and he is doing a lot better with a significant hamstring problem than he had. The problem is there's really no evidence, and in some cases, negative evidence for yoga, myofascial release, cupping for the non-operative treatment of scoliosis. Botox is another area where you know, there simply is no evidence, and potential, in the latter example, potential downside. Basic science studies have now led pediatric orthopedic surgeons to have some concern about using Botox in kids with cerebral palsy with spasticity because of evidence that you can be harming the muscle unit and causing scarring. So I think we really need to be careful. To do a study like that, I think would actually be really hard to get through an IRB because of the potential negative effects and the lack of any even foundational evidence about the advantages here. So again, when there are good treatments, it's hard to experiment. And I look at you know, our history with electrical stimulation as the same. Yoga is interesting because there has been a little bit of work and some empirical studies showing some advantages of some potentially of yoga. And I'd like to lateral that question to Prachi, one of the co-directors of the CME tonight, and one of our amazing Schroth physical therapists, to give us a little bit of perspective about your views of yoga for AIS. Prachi, you there?
Before you do that, can I just give a quick comment on the Botox? Is that it actually is, people have tried it on the brachial plexus palsies. And the problem is that when you denervate the muscle, you actually end up making the muscle shorter, which is not what you want to do. And that's really the opposite of what they've been doing with the proteasome inhibitors, which is to allow those muscles to elongate. So it's actually contrary to the evidence that's out there in contracture formation. And I'll turn it over to Prachi for the rest there.
Dr. Sanders. Thanks, Dr. Vitale. Yeah, it's a really great question. I think there's been a lot of work done on modifying yoga poses, modifying even Pilates exercises, and just allowing, you know, just being mindful to curve patterns a lot. And there's been also a lot of work in training yoga teachers, Pilates teachers about this. And it's part of our talk is just slowly incorporating regular daily exercises in addition to PSSEs, just to allow the patient to be very well-rounded.
So Michael and Prachi, thank you very much. We're right at the time, and in order to keep the course on time, I'm going to turn it back over to you, Michael.
Well, thank you very much. I see there's a lot of questions, which is great. Please keep them coming. I will do my best and also ask the panel to feel free to answer some of these questions. Have questions about the best practice guideline, I'll try to send that, for example. And I just want to, in a second, thank Prachi Barkarnia, who has been a great partner in this area of conservative scoliosis management and is one of our great scoliosis-specific physical therapists with Kelly Grimes at our institution, who is my co-director of this course and has done so much work, as well as Amber Santel. I think everyone knows Amber. She is our right hand in this endeavor. So thank you very much, Amber. So to stay on time, we will now hear from Ben Roy, my partner, about what we have learned from 3D analysis of in-brace x-rays. Thanks, Ben.
Okay, well, I can't start my video, but I'm going to share my screen here. Here we go, share. All right. Hold on, let me get to the beginning here. Okay, so I'm going to talk a little bit about both our best practice guidelines, as well as some things that have been mentioned earlier about axial rotation and how we can, and its impact and influence on brace treatment. So just start talking about the BPGs, or best practice guidelines. We know that bracing is certainly a mainstay of conservative treatment of AIS, and there's a lot of variability that exists in practice that I'm sure we all see with regards to, can you guys see my slides?
Yes, we can.
Okay, great. All right, good. So sorry. There's a lot of variability that exists, like what type of brace, how long do you brace for, when do you brace, all these types of things. And there's really a lack of evidence for many of the recommendations that are out there. And just waiting for evidence to accumulate to catch up and support recommendations that people make probably is not something that's going to happen in a reasonable amount of time. So we really felt in our group that there was a strong need to develop these practice guidelines for bracing in the interim to at least have some structure to it, allow us to study it a little bit more detail. So our goal was to develop these VPGs for bracing using formal consensus building techniques. We gathered a multidisciplinary group of international bracing experts, and these includes people in a variety of fields, including orthopedic surgery, physiatry, physical therapy, and orthotists. And we first we went through and established what the current practice patterns are, and this was done both via literature review as well as with interviews with a variety of providers. And then from that, we were able to develop and distribute surveys that we then submitted to experts. And we then developed consensus. Consensus was defined by convention as an 80% agreement. And this was done through iterative surveys and an in-person meeting. And through this process, which took several months, we were able to achieve over 60 items of consensus, which certainly on the surface sounds amazing. But you'll see that a lot of these items of consensus are relatively broad and they're not incredibly specific. So I'm going to go through some of these things that we found, and they're sort of broken up into several categories. We looked at goals of treatment, bracing indications, defining risk, how exactly do you prescribe the brace, how do we assess the outcomes radiographically, what sorts of physical activities, physical therapy, and how do we discontinue bracing. So this is not everything because that would be way too long. I only have about 10 minutes here, but this is sort of the highlights, I think, of what we found. So talking about goals of treatment, I mean, this is something that was pretty straightforward, but it's important to enunciate. And again, the primary goal of bracing in AIS is to prevent or limit curve progression, including progression to surgery in the growing child. So that's what we're looking to achieve. And again, remember, this is in the growing child. So getting exact indications on when to place somebody in a brace is difficult. So we kind of looked at when do we not want to use a brace. And even here, we had pretty broad indications. We decided that bracing was not indicated in either very small or very large curves, defined as less than 15 or greater than 60 degrees. And also in the skeletally mature patient. Again, our goals are to brace patients that still have significant growth remaining. And we define skeletally mature as those who were RISR 5, Sanders 7, or they've been documented with minimal to no growth over the past year. These patients are really not generally brace candidates. So what about brace types? Well, we certainly decided that there is a difference in effectiveness between different brace types. And broadly speaking, rigid braces, such as the Boston brace or Rigaud-Chenot, are superior to non-rigid braces, such as the SpineCore, which certainly has been borne out in the literature. Additionally, it's really important to know what you look like in the brace. And if a properly worn brace does not achieve meaningful curve correction on X-ray, you really need to modify or remake the brace. Otherwise, you're not really accomplishing anything. What about the prescription? How long should patients be in the brace? again, people are all over the place, so the recommendations are generally broad, but patients that are considered high risk should really be braced a minimum of about 18 hours a day. Some people go as far as 23, but 18 was an agreed upon minimum. Less than 6 hours a day was really decided to be completely unindicated. The studies have shown pretty definitively that you're no better than natural history by wearing it less than 6 hours a day. And in general, when possible, you really should look at compliance. There's a lot of benefits to doing that. What about imaging? In general, when possible, as Dr. Sanders just said, he doesn't have his yet, but using low-dose biplanar radiography, such as the EOS machine, is certainly preferable when possible. It's lower radiation and gives you a better assessment of what's going on. It really is important to evaluate skeletal maturity. This did achieve consensus with the Sanders staging system, as Dr. Vitale said. We've shown that in about 20 to 25% of cases, the Sanders and the RISR scores do not correlate. They either under or overestimate the amount of growth remaining. So making decisions based on based on RISR is really a mistake. Additionally, if someone has a leg length discrepancy, you should probably correct that when getting the X-ray. Again, as we said before, in-brace X-rays are really important, and they should be done after a break-in period of somewhere between 2 and 6 weeks. You should look at the lateral X-ray as well. Scoliosis is not a single plane deformity. Subsequent X-rays should be taken, however, out of the brace. You want to see what's going on out of the brace. You might be masking progression if you just take in-brace X-rays. And the brace should be removed before the X-ray. Consensus was at least an hour, but variability was wide, anywhere from 1 hour to several days. What about how often do we need to take X-rays? Well, there was certainly agreement that if you're growing more quickly, you should have X-rays more frequently, every 4 to 6 months, than if you're outside that rapid phase, when maybe you only need X-rays every 6 to 12 months. For PSSEs, or the scoliosis-specific therapy, not a lot of consensus. It's not a very strongly worded statement, but it was agreed that you could consider prescribing these exercises along with bracing when it was available, because certainly we know that Schroth therapists are not available everywhere. And it was not to be considered a substitute for bracing when bracing is indicated. What about discontinuing bracing? Well, skeletal maturity, size, and changes in height are going to be factors that you need to incorporate when making this decision. But as far as definitive recommendations, those were not made. We couldn't come to consensus upon that. We did agree that there should be a weaning period for 6 months at least. Some people weaned for 2 years, but 6 months was considered the minimum. This is sort of a flow sheet that's in our publication that looks at, again, the vast majority of these factors and what we came up with best practice guidelines. I'm just going to kind of summarize quickly, which is that, again, we've seen significant variability exists in bracing patterns. We did develop these broad-based best practice guidelines based on a systematic review and expert consensus. Adherence to these guidelines will reduce variability, which we know will certainly provide better outcomes. Less variability will almost always lead to better outcomes. And we also were able to provide some structure for future research going forward as to better define these guidelines as they exist right now. So I'm going to change gears a little bit and talk specifically about the role of the axial plane and bracing in kids with AIS. So again, as we've mentioned multiple times today already, I think Michael mentioned this in his first talk, AIS is a three-dimensional deformity. We have the coronal or frontal plane, which is the most obvious one, the one that we think about initially. There's the sagittal or lateral plane, right? So that's one which is also important as well. We know most of these kids are hypokyphotic, and that's important to consider. But then there's the axial plane or rotation, which is not quite so easy to understand because it's not easily seen on x-rays. So we talk about this concept of axial vertebral rotation, and this is an assessment of the vertebral rotational component in the spine. And again, this is what you see when you bend them forward in the screening test. You see their ribs are asymmetric, and that's a secondary measure of rotation. It's difficult to measure on plain x-rays, but 3D modeling does make this easier to do. As you can actually see the vertebral body and measure them in space, and you can actually measure how rotated they are. However, there's really very little known or described about the role of this rotation on bracing outcomes in AIS. So we did a study. We wanted to look at the way bracing affected the axial plane and how that in turn affected treatment. So we looked at our brace patients with at least 1 year follow-up and imaging done with EOS, which allowed us to do three-dimensional reconstructions. And our main outcome was looking at treatment failure, which was defined as curve progression of at least 5 degrees. So ultimately, we ended up having two cohorts of patients, 75 patients that had at least one EOS image in the brace, And there was a subset of those patients, 31, who had both pre and post EOS imaging, meaning that we could see what their backs looked like before the brace and after the brace. And these two groups were completely comparable with regards to age, gender, and curve factors. So when we looked at the absolute rotation in the brace, we saw that those that failed treatment or who had progression had much more rotation, about 10 degrees, compared to those that were successful, 6 degrees. Well, this looks pretty great. However, when you go and look at it more closely, rotation does correlate tightly with your major curve. So that means how big your curve is when you start bracing is a confounder. And when you then control for that, then this finding kind of falls out, meaning that when you're controlling for the size of the curve, the amount of rotation that you have in the brace does not any longer seem to be a predictor of success or failure. It's really just the curve size, which is a predictor. However, if you then just look at the subset of patients that had improvement in rotation, meaning, so before they go into a brace and after they go into a brace, those patients that had less rotation in the brace had an 85% reduction in risk of treatment failure compared to those that did not have improvement. So this is pretty good evidence showing that we like to have good axial rotation control in the brace. This is what Dr. Sanders was saying earlier. He likes to have a derotation brace. And this is some of the first evidence showing that that really does matter. So again, in conclusion, I think I'm up against my clock here, but patients that had improvement in rotation with bracing had 85% reduced risk of treatment failure compared to those without. We certainly need to do this with a larger group with hopefully a little bit longer study follow-up, and it justifies the need for a multi-center study to do this. And we actually have a grant to do this, and that study is going to be ongoing. So I'd like to thank you very much for your attention.
Thanks, Ben. Great talk. And there are some questions coming out. Maybe you can answer the question about where that is published, and you can send that to everyone. While our next speaker, John Tunney, who is my right hand literally every day in the office, will speak about what's the ideal brace. Thanks, John.
All right, let me get my webinar set up here. Is everybody able to see me? All right, thank you.
Perfect.
Thanks for having me tonight. I'm going to talk a little bit about ideal bracing for JIS, actually. So the definition of juvenile idiopathic scoliosis is classically defined as scoliosis that's first diagnosed between the ages of 4 and 10. This category compromises about 10 to 15% of all idiopathic scoliosis in children. So what are the options in treatment for these kids? We have observation. So what we know is that if curves that reach 30 degrees routinely worsen, maybe we shouldn't be observing so much. Why wouldn't the goal be to make sure they don't get to 30 degrees in the first place? If we only wait and see, we might be missing out on the preventative piece that we have available to us. But if we only treat patients, even patients with small curves, we might be treating patients that don't really need it. And that is one of the problems that we have when making decisions about who to treat. We have physical therapy. Some of the confounding factors in these kids who are very young is, are they able to actually do the exercises? Can they really focus long enough in a physical therapy session to get benefit from it? I don't necessarily know that we have the answer to that. Is there an advantage to starting at an early age, where if we teach somebody something young, they maintain it a little bit better throughout their life? Also, is there a downside to doing physical therapy in these young kids? Some of the downside is you might not get anything out of it for the kids that really can't focus for any amount of time. I think the decisions for this are really made on an individual basis. For some of the younger kids, sometimes casting is even an option. But a lot of times the kids who come through for JIS are really too old for this to be an option. These are really done on the much younger kids. And then we have bracing, which is my forte. And we'll talk a little bit about some of the new things that we've been doing for bracing in kids with juvenile idiopathic scoliosis. So we have what we talked about a lot is brace prescription times. I think there's 3 main times that are mostly prescribed. We have that full-time brace wear group, which is like the 16 to 18 hour range, which is the most commonly prescribed brace range. We have kind of in the middle of these two things, the home time. And more recently, I've been seeing lots of patients prescribe 12 hours of brace wear. And then you have the bedtime, which is just 8 hours of wear, which Dr. Sanders had mentioned before, might not be the best because there's no time while the patient's really standing up and it's all gravity eliminated. And that what we know from the research is less than 6 hours a day is really the same thing as natural history. So we don't do a whole lot of bedtime bracing for my patients. What are the factors to make the bracing decision in the first place? So we talk about Cobb angle. Classically, I was taught documented progression. Kind of really doesn't matter what curve threshold you get to. If your curve gets 10 degrees bigger in between visits, it seems likely that it's going to keep getting bigger and maybe we intervene sooner. We have patient and parent preference. Some patients are very much for bracing. Some patients want to avoid it at all costs, and I think that's something that needs to be talked about. Family history, as we know. Scoliometer measurements, talking about rotation, as Dr. Roy just spoke about. And then Sanders maturity staging, if available, is important. But a lot of times, these kids are much too young to have that be a meaningful number, and almost always they have significant growth remaining. One thing that we'll talk about throughout the course today is emotional distress that comes along with treatment for scoliosis. I think classically it's always thought of as bracing causes distress because it's something else for the child to do and it's something they have to wear. But both talking about surgery and observation also showed emotional stress. And it was written that 32% of patients actually scored as clinically significant for having emotional distress. And that's probably a higher number than I would have guessed. Age, Cobb angle did not factor into the amount of distress the patients had, which is interesting. Results of bracing in juvenile idiopathic scoliosis. For sure, this is a much smaller group of patients and it takes much longer to gather these patients over time than classic AIS. So you have patients who have gone for years and they only come up with groups of about 125 patients. But what's interesting about this study is that a JIS curve that progressed to 20 degrees was considered a progressive curve and bracing was instituted. A lot of times the number that gets floated out there for the beginning of bracing is 25 degrees. And I think sometimes even when you're talking about measurement error, a 25-degree curve might even be a little bit more than that. There is some evidence for early bracing in kids with rather small curves. So in that 15 to 25 degree range with significant growth remaining. And this was a study that was done just on nighttime bracing. And what was interesting about this study is in the treatment group, 30% of the people who wore a brace to sleep only never progressed to 25 degrees. In the observation group, all of the kids in this group progressed to 25 degrees, and that meant they initiated full-time brace wear. So nighttime brace treatment may reduce progression to full-time brace treatment, just something interesting to talk about given the emotional distress that possibly comes from bracing. We did a small study of some of the patients that I've been treating to assess the short-term effectiveness of part-time bracing. And we define part-time bracing as that 10 to 12-hour range. All of the kids were Sanders stage 1 through 3 with juvenile idiopathic scoliosis. And their Cobb angles were 15 to 25 degrees. And the outcome measure for this brace group was that they did not progress to 25-degree curves, meaning they required a full-time brace. We had 38 patients in the study, so it's still rather small, but more to come for sure as we kind of build on the evidence. And the follow-up was about 2 years. So in our results, 8 of the observation patients, about 32% of that group, progressed to 25 degrees over the course of this 2 years, whereas only 1 of the part-time bracing patients, or 7%, progressed to full-time bracing. When you take out patients that were older than 7 years old, none of the patients progressed to full-time bracing who were wearing the brace 10 to 12 hours a day. So here's just an example of a patient we braced for juvenile idiopathic scoliosis, and a patient that we did not treat early. A patient came in, they had a 34-degree curve. Bracing was discussed, but the family decided to wait. They came back a few months later. All of a sudden, the curve is now 47 degrees, and bracing is initiated, but surgery is discussed just based on the curve magnitude, but the child was still rather young. They came back for their in and out of the brace x-rays on the same day, a few months later. Their 53-degree curve was a 14-degree in brace. And then we have a patient many years later who was in the surgical range, who came out the other side, has a 41-degree curve, has been stable for quite some time. To me, the purpose of treatment is to give the patient what they need and minimize the impact on their daily life, because this seems to be what families want. So I think there is a role for starting bracing early with slightly less hours that might be able to accomplish all of our goals between getting enough treatment, but giving the patients a little more freedom in their day. Thank you very much.
Thank you very much, John. Another great talk, and really provocative, interesting results about part-time bracing in juvenile idiopathic scoliosis, which we're sure to get some questions. In the interest of time right now, we'll move on, and I'll introduce Jim Wayne, an orthotist in Boston, who will talk about the three-dimensional Boston brace. Thank you very much for joining us tonight.
Thank you, Dr. Vitale, and thanks for the opportunity to share with you our experience with the Boston Brace 3D. And good evening, everyone. These are my disclosures. And so the Boston Brace 3D is really just part of the natural evolution of the Boston Brace system. And so as our understanding of scoliosis has improved and the technology has improved, it's led us to develop the 3D brace. So what we call the Boston Brace 3D, it's a custom fabricated from scan orthosis. We utilize blueprinting principles to design the brace as we analyze the x-ray. We're paying attention to the overall sagittal balance with the patient. And in the brace, we have intrinsic and enhanced shifts and push combinations. We'll talk about that in a moment. We also have enhanced void areas of relief opposite those vector forces. The orthosis can be anterior, posterior opening. We can line it, we can have it unlined. So we have many options that we didn't have before. The way the brace was developed is part of our quality assurance program is that we monitor all of our orthotists and we see what type of in-brace corrections they're getting. And we noticed that there was a cohort, primarily in the mid-Atlantic area, that were getting much better in-brace results than some of our other clinicians. And they were early adapters of scanning and CAD technology. And so we utilized either the iPad or a laser scanner. And so we developed first a repeatable process of getting the patient in a good sagittal balance to capture that scan, and also making sure their arms are in a standard position that we didn't negatively impact the sagittal plane. And so here you can see the patient as they're being scanned, and then this is what their image looks like when it's in the CAD modification software. So here we can see a raw scan of a patient. And now through the CAD modifications, we're able to build a lot of these asymmetries or build an asymmetrical model over which we pull the plastic. So as orthotists, when we talk about symmetry and asymmetry, we're really talking about the model over which the orthosis is fabricated. So with the original Boston brace, we were doing that over a symmetrical model, and that was typically by measurement on cast. We still do some with scan. And then we had what we call additive asymmetry. So we created an asymmetrical brace either through the trim lines or pads that were added on the side. Whereas with the 3D brace, we're beginning with a asymmetrical model, and we still believe in this additive asymmetry. So we still have the option of adding pads so we can alter the vector forces, the dimensions of those pads, and the orientation of those pads within the brace itself. And so with CAD, it gives us a good way to visualize what's going on inside the orthosis. So if we take a look at this single right thoracic curve, 41 degrees, and we're going to take a top-down view right through the apex of this curve. And so we can see the asymmetry, the rotation that we've been talking about earlier tonight. And when we go through symmetry or balance, what we're doing is we're just increasing those vector forces. And so we create, when we do an overview of this, so the red line is where the patient was, the orange line is when we go through balance or symmetry. We build within the orthosis all these intrinsic vector forces and intrinsic areas of relief. And then we have force couplers as well, with other forces on the anterior side and relief areas posteriorly. And so with the 3D, we take advantage of that intrinsic forces and then we enhance that. And so we can see here with the asymmetry, we actually build some linear deviation in, we're enhancing that derotational vector force, and then we provide room on the anterior side for the patient to be able to shift over. And this is how that patient did. So she got a very nice in-brace correction, good overall balance. And then we follow her 1 year and 2 years later out of the brace, where we're seeing some short-term reduction of that initial curve. We're paying also more attention to the thoracic pad placement, and we're fairly strategic with that. And where we're positioning this pad, we want to make sure that we don't cross this mid-sagittal line, because we'd be creating a resistant vector to allow the patient to derotate within the orthosis. And so if we take a look at our thoracic brace here, we could note that the pad doesn't cross this mid-sagittal line, and we have a relief area built in to enhance for breathing, as well as derotation within the orthosis. And the glue just gives you an idea of the pad's orientation within the orthosis. We don't want to come too far posterior and giving into or creating more of a hypokyphotic posturing of the patient. Adherence, we've heard a lot about that tonight. So adherent monitors, we use the I button with the software. That's our standard of care. And this is the report that both the physician and the patients have. And we review that with the families when they come in. And it gives us the ability to really celebrate success. So we have a nice in-brace correction here on this patient. And when we look at their ability to wear the orthosis in the first 35 days, they average 11.6 hours. So what's that mean? Well, we have to, that accounts for some of the weaning in time that the patient has. So on the x-axis, we see the days that they wore the brace. On the y-axis is the actual hours. So we concentrate here. So this patient was able to wean in nicely, and then they get into a nice routine. A little bit different than this conversation. Another patient, we had a good in-brace correction, but they're only able to tolerate over their first 38 days, 1 hour of brace wear. So this is a different conversation. And you can tell from the graph that they presented with, they really didn't get into a routine. So this is a different conversation that we would have and a different intervention that we'd have with this patient. We're seeing an overall improvement of balance. And with CAD, we're able to manipulate our axillary extension, the upper portion of the orthosis. And so in this case, we're going to outset that axillary extension so the patient has some room to be able to shift over. And we want to get all these vertebral bodies along the center sacral line. And so that's what happened in this case, where she had a very nice in-brace correction. And her compliance report showed, and this is her second report that we had over 70 days, she was averaging 17.5 hours. So a nice job with her compliance there. The Boston system has always had a coordinated physical therapy program, and it's no different with the 3D. Mickey Guire presented this. Mickey is a Schroth-trained therapist out of Chicago. She presented this poster at SOSORT last year, won an award for that. So this patient was presented to her. They received a Boston 3D and did a series of Schroth exercises as well as other exercises, and had a very good positive result. So there's no reason why this orthosis can't be utilized with the various types of schools. When we look at our outcome data from last year, and we continue to monitor our outcome data regularly. So this is, we're looking at our single curves and our double curves, and here's the degree value where the patient started. We're seeing good percentages of our in-brace correction for both our single and our double curves. So we continue to monitor that and make adjustments as we go. Same thing with our adherence data. And so this is adherence data for the first 6 months of 2019 on patients who opted to have the I button installed. And we recommend 18 hours a day, as has been talked about. And so for the most part, our patients are able to tolerate the orthosis and wear the orthosis the full amount of time that's being recommended for them. So we continue to monitor this. We have a group that meets every Tuesday, and we essentially have grand rounds, and we talk about the different types of design and ways we can modify and change the design, subtle changes that we make just to improve results. So thank you very much.
Great, thank you very much, Jim. I enjoyed your presentation. And there will be some questions for sure. The last talk in this session will be done by our therapy team together. Mm-hmm. Can different schools of PSSC work well together?
And actually the title has somewhat changed. So here we go. I'm Kelly Grimes. This is Prachi Bakarania. And thank you so much for having us. We are excited to co-present. It's a marathon, not a sprint, how to try to do what's best for the patient and not just their scoliosis curve pattern. And Prachi and I talk about this a lot because I think we both feel like it's easier said than done. Next slide. Prachi's controlling the slides. Patient-centered care, and really if we want to extend that in the world of pediatrics to family-centered care, is an approach to healthcare that is both respectful of and responsive to individual patients' and families' needs and values. And the crux of our talk is really from the perspective of the physio or the physical therapist. How do we better take into account the patient in our clinical decision-making process outside of just the shape of the alignment? And to do that, we have to understand who the patient is in front of us. I think everybody's made this point clear that really a lot of these decisions are made on a case-by-case basis. Who is the patient? What is the family structure surrounding them? What is the friendships? Is this patient someone who orients themselves more towards movement and sports, or is this kid someone who prefers art and drawing, perhaps more of a sedentary activity? What is the level of resilience in this particular patient and family? Resilience being the ability to respond to adversity and continue on with life development. And then for who are we, the physios? And what do we bring to the table? We all bring this overarching physical therapy education. And then all of us have our various scoliosis specific education, our own cultures, beliefs, and biases, our communication skills, and of course, our capacity for empathy. And so the marathon begins when at some point during growth, scoliosis is detected. A race plan is formed and we set about on our course together. And if all goes well, we jive with our families, our patients wear their brace as recommended and perform exercises as recommended. And at the end of the marathon, are free from surgery and better off than when they started. But I think we all know that in this particular marathon, like many life experiences, the course more often than not looks like this. And why? Partly because we're in the business of dealing with human beings and family structures and within a larger healthcare system, and children and adolescents at that. For those of us physios embedded in the work of scoliosis, we learn concepts and tools based on the ability to recognize various curve patterns, to take our patient from their current alignment to a more centered and sturdy alignment in 3D. Really the art, skill, and the magic in this training process is the how, considering each patient's unique variabilities. And in some situations, like for example, this particular patient on the slide, things go fairly seamlessly. This patient is 14 years old, so she's a bit older, she's a bit more mature. She is also a dancer of many years, and although that means she may trend towards the more mobile side of the spectrum when it comes to joint and connective tissue mobility, she's also spent years paying attention to her body and responding to the feedback of dance instructors. When asked to describe her perception of her alignment in a mirror, she does so accurately and with ease, and that's one of the great principles that's come out of the SEAS training from the Ithaca group in Italy. She and her mother from the get-go started training and practicing together on a daily basis consistently without really any prompting or nudging from me. It just was is. And although we don't yet know where her marathon will end up, she is progressing at a steady pace. This is what we would argue is the smaller occurrence. The larger occurrence is real life. And I'm going to hand the mic over at this time to Prachi, who's going to, through a mock patient, discuss some of the other variables that we factor into the training process and the work. Thank you.
Thank you so much, Kelly. Hi, everybody. I'm Prachi Bakarania. Today, we're going to meet AD. She is an example of a patient that maybe we have on our schedule. Maybe we're fortunate enough and already have her x-rays available before the session. We do our measurements. And in the BSPTS coursework, we label her a right 4C curve pattern. And then in your mind, you already have 5 or 6 exercises that you think would be most appropriate with her. And then during the evaluation, you learn more about the patient, you learn about her interests, her social supports, and then depending on how she answers, we might be giving some more questionnaires, the Brace Belief Questionnaire, the TAPAS, the TAPS, the SRS-22R. We also do a very thorough core strength assessment, not just of the abdominal wall, but also the vocal cords all the way down to the pelvic floor. And then we try to leave some time to at least have the child leave with an activity that they can practice on their own. So in this example, AD is 10 years old. She hasn't found a physical activity she enjoys, but she loves to read and draw. She's very apprehensive about her brace, hasn't told many friends about it, and she's nervous about what her classmates will think of it at school. She also makes a little note about how she has a lot of flexibility. So when we start talking about how we measure core assessment, this is based on our coursework of BSPTS, the work of Mary Mastery, as well as dynamic neuromuscular stabilization, or DNS. And essentially want to know how well is our patient able to coordinate the cylinder or soda can that makes up their core, with the core being everything from the vocal cords at the top, the diaphragm in the middle, and the pelvic floor muscles at the bottom. And how well do these interplay to form a wall of the cylinder? And then can our patients coordinate these muscles in various positions? Are they able to breathe? Are they able to keep a neutral spine? And are they able to move an extremity? So in our example, say prone on knees, another BSPTS exercise is one that you feel is a good exercise for her. But in quadruped, she has a hard time maintaining neutral spine. She's very hard time breathing. So this might be where we start. You can also encourage using a ball, which is fun. It also allows her to engage her core and start teaching her how to maintain a healthy IAP. We also really like using SAES a lot, and one of the reasons why we really like SAES is it allows the patients to give some input on their own perceptions of their posture, and this gives us a little bit more insight. This is a very busy slide. I hope everyone takes some time just to look through it, but for time constraints, I'm just going to talk about self-image. So say in the evaluation, there are certain variables that come up. For example, the child is not giving a lot of eye contact. The parent is answering most of the questions. They're very apprehensive of taking off their shirt. They won't really look in the mirror. Then this automatically signals for me to give them additional questionnaires, as well as maybe being a bit more empathetic about having the curtains drawn, allowing them to wear a tank top or a form-fitting t-shirt, and not really using the mirror as much as I normally would have. The big conclusions we want to talk about is, treat the patient, not the scoliosis. Remember, you are a PT first, take your time and communicate with the entire team, with the child at the top, with the parent, the doctor, the nurse practitioner, and the orthotist. These are links that we'll make available of all of our the courseworks we've taken, our mentors. These are our email addresses. We'd love to hear from you. Thank you so much.
Thank you very much, Prachi and Kelly. Ross, can you please allow me to have video? Thanks. I think you heard in that last session from a surgeon, two skilled expert orthotists, and two skilled expert physical therapists in this space. And what Prachi just said is really the point, that the best care of these patients requires a multidisciplinary approach from all of those professions. That's the way we're going to make care better for these kids. So I want to thank all of the people in the previous session. First question will go to Dr. Sanders. Is there a link between neurotransmitter imbalances and AIS? Dr. Sanders?
Yeah, so at least one of the genes that's been identified for idiopathic scoliosis is related to transmission of the neuro signals. And so it has to do with the development of the nervous system, particularly of the peripheral nervous system. And so it's likely some asymmetry that's occurring there, not specifically to the transmitters themselves, but the development of the system.
Thank you. Jim Wynn, I'll ask you to answer my question about the evolution of Boston braces. And this makes so much sense. I think so many people are happy to see that. Do you have evidence about lower rates of curve progression and curve progression to surgery, as we're seeing in the other 3D Rego type braces? And do you have data on sagittal and axial plane in brace correction yet?
Yeah, we're starting to collect the sagittal plane correction. We just don't receive many lateral x-ray. So that's been a challenge at our institution. So some of the physicians are starting to collect that data, and then we'd be able to report out on it. I think too, we really started working and scanning on this probably 4 or 5 years ago. So it's a little early to do long-term data to see what the surgical rates are in those patients. But what we are seeing in its trends, and we need to publish this, is that some of the correction that we're obtaining in the orthosis, we're seeing that being maintained. So we're noting when the patients come out, and typically the patients at our institution are out of brace the night before. So they fall into that group that's probably 6 to 12 hours out of brace prior to the out of brace x-ray. That we're seeing those curves are maintaining some of that correction. But we need to study this long term and really do a more rigorous review. It's anecdotal right now.
Got that. So given, good evidence and emerging evidence that the 3D brace is better, is there still a role for the traditional Boston brace? If a patient comes in and sees me in a Boston brace, should I encourage them to be switched to a newer design, or how would you approach that?
Yeah, well, I think, the original was just custom made for measurement. So we were taking patients and we were fitting them into prefabricated modules, and then they were customized to the patient. Today with scanning technology, I think every patient should be scanned. We should be customizing these. We can fabricate these in CAD. So we're switching our patients over. Anyone who comes in that may have been fitted with a traditional style, we're switching all our patients over to a 3D.
Great. Ben, a question for you. Talk to us a little bit about how you will be able to show patients that 3 dimensions matters. I think the question specifically about what if you don't have EOS X-rays at a certain institution?
So, I guess the question is that, are we showing the patient, or are we talking about the whoever's treating them, whether it's the therapist, orthotist, or orthopedist? I think the easiest way to see it clinically, obviously, is with the forward bend test, and you can see the rotation in the ribs or in the paraspinal musculature in the lumbar spine. And there's no question that so many children, with a good derotational brace, when they come back for follow-up over time, have improved rotation. Sometimes even their curves may not have sustained improvement out of brace, but that rotation does seem to improve. And it looks like that's probably a predictive factor to help protect against progression. So that's something which they can certainly see. The families can see that, the kids can see that. And I think that's a really powerful tool for them.
Yeah, the challenge, as Jim alludes to, is not every center has EOS. Not every center has the same level of support with regard to orthotists, and it's a challenge. It's one of the reasons why there's so much variability. Well, great. At this point, I think we should move on. We are exactly on time. I want to be respectful of people's time. I'll thank the previous presenters and ask Dr. Benjamin Roy to moderate the next session. The first talk is a pre-recorded talk by Dr. Elisabetta D'Agata, who is in Italy right now. So her talk is recorded. She is a well-known expert in this space, well-known among the physical therapy community. And I've asked Prachi to jump back on and just provide a little bit more of a formal Elisabetta introduction to Dr. D'Agata.
Oh, I would love to. Dr. Elisabetta D'Agata is a psychologist who specialized in teenagers, adolescents going through experiencing scoliosis. She talks a lot about self-image. She talks a lot about behaviors, even how you presenting yourself as a healthcare professional. Her course was incredible. It changed so much of how I conduct my sessions, how I'm so aware of patients' nonverbal cues, and I hope everyone enjoys her talk.
Thank you very much, Prachi, and let's play it.
Hello, everybody. I am Elisabetta D'Agata. I'm a psychologist and a psychotherapist. And here I would like to share with you my experience in the treatment and the study of the adolescents with idiopathic scoliosis. I started working with the patients like 13 years ago, studying and working on my PhD about the quality of life of the adolescents with idiopathic scoliosis. But the interest started before, as I was one of these adolescents treated by Milwaukee brace, and this experience marked me a lot. So when I became older, I decided to study more, to know more about the life of these patients, and above all, how we can help them to live this time, this period of their life, in the better way they can. So let's start with the presentation. I will present the model, the framework, where we move as it is a map. And this model is the biopsychosocial model. The first person that talked about it was an American psychiatrist, George Engel, who presented his article in the journal Science, showing his dissatisfaction with the current biomedical model. The biomedical model was focused mainly on the physical illness, while the biopsychosocial model is related to the biological disease, the physical disease, but also to the human experience, was his interest in knowing how people are living their disease, and also how is their relational world, because now we know that it is very important to have a social interaction during the disease that help people to feel stronger and safer. So the biomedical model was not wrong, what was only incomplete, and the biopsychosocial model comes from the theory of the systems, which considers that each part of the same system is inextricably interconnected with the other. So the biological aspect, the social aspect, and the psychological aspects are strictly interconnected via feedback loops, and if one part change, all the other part can change because they belong to the same system. And to help us to do this, we have to integrate objective measures like Covengor degrees, like research, like ATRI, with other measures that are subjective measures, for example, like the health-related quality of life instruments, tools, questionnaires that are present in the scoliosis field, and also with the interview. The contact, the knowledge, the information about the human person that you can receive talking with your patient is extremely rich for you. It means that only a treatment based on the mechanical of the body, with brace, with surgery, or with physical exercise is incomplete and reductive. We have to enlarge our look, we have to integrate other dimensions, we have to go beyond scoliosis. This model, the biopsychosocial model, was based on the definition of health of 1948 made by the World Health Organization. They say that that health is a state of a complete physical, mental, and social well-being. But now this definition is considered a bit old because of the demographic change of a population that is aging. We have a lot of chronic disease that are very common, so that health is a state of complete well-being is a bit an utopia. So I like this proposal of a group of researchers, and arrived to the conclusion that health is not a state but is an ability. It is an ability to adapt and to face physical, mental, and social challenges. So the ability of managing, of facing challenges is really a psychological ability, and as professionals from different fields, from doctors to physical therapists to orthotist technician to psychologist, all of us, we have to push people to grow in their concept of their health. So it is key now the communication with our patients and also with his or her family. So it is really important, above all in the first visit, to normalize the situation. Says, yes, she has scoliosis. I have met a lot of people with scoliosis. There are a lot of adolescents with scoliosis. Here is the right place. You find the right place. I can give you opportunities. We can find together solutions to depathologize, to keep away people from the drama situation. They are in a dramatic situation. They are in a survival state. So we have to help them to shift to a situation of safety, where they can understand that there is something that can happen, that is something that is common, that there are people with scoliosis that are famous, that scoliosis don't stop them. People achieve their dreams. Fashion models like the daughter of Madonna, who the singer, the pop star, the fastest man in the world, the Jamaican Usain Bolt, he has scoliosis. The musician Yo-Yo Ma, the violinist, is operated, fusioned for scoliosis. So scoliosis cannot stop the life of a person, cannot destroy the dreams of the person, the goals, the life goals of the person. Then take care of using a specific word, specialistic language, above all in the first visit, because it can interfere in the understanding of the patient and the family, also in the relationship that we are creating for the first time with the family, and above all with the sensation of safety, because they are in an unknown place, they don't know the professional, and also we are using Risser and Covengo and Atri and deformity, etc., and so they cannot receive all this information. It's too much stressful. So at the first visit, we can explain, we can give some written information that they can read after in their house. They can ask questions and they can write their question for the next visit, etc. And take care with the word deformity. The word deformity is a word that is very common in scientific language. We use this word in its neutral etymological meaning, that is deformity. De means alteration of the form. So it means scoliosis, mild, severe, medium scoliosis. We say mild deformity, mild scoliosis, the same. But in the colloquial language, deformity is associated to monstrosity. When we see deformity, she has a deformity, we are destroying, we are damaging the body image of our patient that we want to help. We want to promote body image concept, but sometimes the words doesn't help in this aim. So take care with this word. We can use other synonyms like anomaly, alteration, curve, asymmetry, deviation, etc. And then about the physical examination of our patient, I suggest you to ask permission, to ask consent, because sometimes it's something automatic. Okay, we do the examination, the girl, maybe she doesn't wear bra, so she feels ashamed. We can ask her permission, we can explain why, what we are doing. We can ask if she wants that the father stay there, or maybe he can go out, and then we can call him later, for example. And all these movement of all this communication that we are doing are making a contact, are creating a contact, a human contact with our patients. So it is important. And now 3 tips that I think are important to promote the inner concept of health for our patient. First of all, they are related to the words, to the use of our language. that is a so powerful tool. Instead of say the patient, we say scoliosis. We identify scoliosis with the patient. This way, this manner to refer to the patient comes from the biomedical model. The focus, you remember, was on disease, not on the patient. I suggest you to say adolescent with idiopathic scoliosis. And this will change everything. So there is not an identification with scoliosis, there is not a reduction with scoliosis, and this arrives to our patient. It is really important that the patient can receive the message that his or her life beyond the scoliosis is worthy, and she has not to dedicate all the life making treatment. The second tip is about taking care of says that you have to fight scoliosis. In this expression, there is the idea that scoliosis is an enemy, and so the patient is converted in a warrior of scoliosis. But the idea of fighting with a part that is inside, because scoliosis is not outside, is inside, sometimes is not good, because it is like a fight, a battle with a part of the person. So instead of fighting against me, I can take care of my spine. And the third point is related to the construction of the relationship. So first visit has the main aim of creating a relationship. More than correcting, it is important to connect with the patient there and the family. To do this, we have to take care of the communication, as we have said before, and to start to create a relationship that is based on empathy, on trust, where we can explain the treatment, we can explore the expectation of the patient about the treatment, and also we can arrive on a mutual agreement on the goals on the treatment. Why it is so important to create a good relationship with our patient? Because the therapeutic alliance is the best predictor of the adherence to the treatment. Can start asking questions, we can support them in their social relationship, because the brace scoliosis can be an obstacle for their social life, and this period is so important for the social life, learning of social skills. They cannot be isolated. They cannot be home studying only and making exercise. It is not healthy during adolescence staying home. So we have to push them to have a social life, to be creative, to express emotions, and to stay in group. And we can also try to inspire our patients making questions that can be interesting for them. Who am I? What kind of life I want? What kind of job? What kind of family I want to make? Where I want to live? Because they are these are the sensitive questions that are hidden in the adolescent mind. And we have arrived to the end. Thank you for your attention. Bye bye.
You're muted, Michael. Can't hear you.
Yeah, sorry about that. Incredible talk. And here you really see the full spectrum of our ability to affect patients. And you see how much we're missing by being the blind man only feeling the trunk of the elephant or the nose of the elephant or the leg of the elephant. There's such an incredible opportunity to engage our patients, both in their physical care, but also in their emotional and psychological care. And I really appreciate the last talk highlighting that. Finally, as we come to the end, I will ask Prachi to introduce Amy, who is going to speak about cultivating a high-performance scoliosis care team. So critically important.
I can't start my video, but I would love to introduce Amy. Amy is one of our mentors. She's an incredible instructor, friend. She's a private consultant, but has developed this amazing interdisciplinary group in her community. And we've asked her to talk about the process that she's used to be very successful in what she does. Thanks, Amy.
Thank you. What a nice introduction. I appreciate that. And I appreciate being here tonight. I cannot see myself or anybody else right now, but so I'm just kind of speaking to a screen. But I appreciate you guys having me, and I'm looking forward. I really enjoyed that talk too. And I'm looking forward to sharing some of the things that I've learned along my way. I've been doing scoliosis specific exercise for about 15 years. And I've moved a couple times in my career. I'm currently living and working in Lexington, Massachusetts. But every time I've moved, I've been in private practice settings in states that allow direct access. So tonight I'm going to share a few highlights that I've picked up along the way about how to help cultivate a highly performing team. And I've had the opportunity of working with great teams in the different locations that I've lived. And it's these scoliosis specialists in the regions where I've lived that have made the teams that are working with me for the patients. So who makes up the team?
Sorry, we need you to share your screen. Sorry, we can't see your slides yet.
Well, let me do that again. Let's see, there we go. Sorry about that, guys.
Great.
So slideshow. Okay, there we go. That's why I couldn't see myself or anybody else. Okay, so here is the team roster. And I think a lot of people have talked about people on this team already tonight. And I would like to highlight the bottom row. And I've highlighted them to made them bold because I lean into this group of what I would say important professionals in the care of our patients that might get overlooked. You know, there's that kid who's willing to wear their brace to school, but feels really full when they eat lunch and they don't know how to get around that barrier. So, you know, writing a letter to the school nurse and asking for a little bit of extra space and time for the patient to be able to go change their brace, and maybe getting a hall pass because lunches are so short anyway. So being able to get to class on time and reducing that stress. I've heard multiple times, I can't participate in gym because I don't want to open up my brace and hear that Velcro echo in the gym locker room when I'm taking off my brace. And so, you know, even helping the patient kind of self-advocate, going to get care for themselves to be able to wear that brace, because the alternative is they leave the brace at home. So don't neglect to use some of these other professionals on the list here. And then you might ask, what are the elements of a high performing care team? I think we would all agree that these four things are important. I mean, having the shared goal of stopping curve progression, having professionals on the team that have lots of years of experience in scoliosis management, having evidence-based treatment plans, and communication. And as I was thinking about this talk and I was thinking about how to narrow down this important topic into 7 minutes, I was like, man, communication is the most important thing. It has to be consistent, clear, and open. And there's many aspects of scoliosis care, as we've even talked about tonight. Dr. Vitale mentioned, and one of the examples I was going to use is, when's the best time to start weaning a brace? And when you do wean a brace, how do you do it? You know, you said something about 6 months. In my mind, I'm like, what are the details of those 6 months? So there's just lots of areas that, you know, the patient gets told something And I want to be able to support that team in that decision of whatever is being told to the patient. So communication is vital to the patient's success. So a couple pearls in cultivating the team. Again, I'm kind of following a hard act to follow around listening to the patient, but I think I'm back to that topic of communication. Listening is a form of communication. I am in total agreement that that first appointment is all about building rapport. It is so important. So connecting with that patient, learning what their barriers are, dealing with their concerns up front is a very important part of care. Answering questions, sharing resources. I put a couple resources at the bottom of this page that I share often. The Braced book by Ali Gerber is about an athlete who's wearing a brace, and so that's great for athletes. Some girls like to talk it out, so Curvy Girls is a great option for them, and they're meeting on Zoom now, so there's fewer barriers to getting together with others. And some introverts, I have a great poet here, Maddie Stepanek, who had a chronic condition and wrote very calming and beautiful poems. So different ways to connect with them and sharing other resources, because knowledge is power. And then responding to these barriers or concerns or questions by maybe referring them to somebody else to answer these questions for them. And then I feel really fortunate that I get to see the patient probably the most than other people on the team, I guess, other than school providers. I feel like I like that I get this opportunity, and I want to use it to the advantage of the whole team. And so really making sure that I'm encouraging adherence to the brace every visit is part of my subjective information. You know, how long are you wearing the brace? How much are you doing your exercises? How many times a day? What exercises are you doing? Trying to figure out what the barrier is to getting that done. And I always am checking in, when's your next brace check-in, when's your next doctor's appointment, are you staying on the schedule, those kinds of things. So helping the family stay on track with everything. I think it's super important that everybody on the team is responsive. I try to stick to, and I prioritize other people on the team. You know, I have that 24-hour return of email for people on my team. And I think it's important that it's a goal of all of us to help the families get that information back fast. I often like to flip the script with people too. People on the team want, I need to know what they need from me. I have had many conversations about what to look for in the brace that shows me that they've outgrown the brace, because I don't do x-rays. I get x-rays from afar. So when it's been a while since the brace x-ray or something like that, I'd like to know that information. And then I need to know, how do I get a hold of you when I have something I need to get back to you about? So sharing case nuances to help the care plan make adjustments quickly for the patient's best interest. Some pitfalls, maybe some of these are personal experiences, some of these are things that I've seen from others that I want to share. So making assumptions that the patient has great recall on what the doctor says about the plan of care or x-ray measures. Make sure you go directly to the team to get that information. And I think making the assumption that all patients that have scoliosis are a fit for PSSE or bracing. I have, the cases where you would think it would work out great. You have a supportive family, they show up, they're, they have the brace, they're doing their doctor's appointments, everything seems like it would be great, but there's, coping issues. There's, I can't concentrate when I wear my brace to school. There's, I can't learn these exercises in a meaningful way when you're not with me. And, I've just learned that there's a time to say uncle, and, you pushing your agenda is maybe adding stress to the family. And it just needs to be communicated back to the physician and the orthotist. It just looks like it's more trouble than it's helping in this case. Don't avoid missing feedback from your patients and from the team. It's only an area of ability to help you grow. Don't hold back negative outcomes. Actually, the opposite should happen. That's the time where you need to jump in and say, what needs to happen? Do I need to increase my plan of care visits in frequency? Do we need brace adjustments? Do we need to get the kid back to the doctor? Do we need to change the plan of care altogether? Contradict. This is a big, big problem. Do not point out theoretical differences between people on the team. if you have a problem with a minor measurement difference, or there's something that you don't understand that the patient's relaying to you, make sure you go directly to the person, make the adjustments between yourselves that you need to understand each other, figure things out, and get back to the family right away if there's been any conflict. And that's something that, excuse me, is divisive and not helpful. So those are the things that I would recommend avoiding if you're trying to cultivate team cultivation. So in general, overall, coordinating the team communication and advocating for the patient within the team will give us the best results. Okay, so here's my contact information. If you want to talk more about this or reach out to me, this is how you would do it. Thank you.
Thank you, Amy. That was a really great talk, and just kind of highlights some of the importance and the complexities in managing these patients. There's so many people that touch these patients along the way, and it's really important that they communicate, as you highlighted so nicely. I'd like to ask you a couple questions about that. So, how do you go about trying to really identify other people that can be supportive of the patient, especially in relation to Dr. DeGatta's talk about emotionally supporting these patients? I know that from our experience, Kelly and Prachi do an amazing job supporting these patients, calling them after hours, contacting us, and letting us know what's going on so that we can all help be there. But that's not available for everybody. So do you have a way to try to help to identify who the best person is? I mean, you talked about different people. I mean, the social workers, psychologists, nurses, things like that. But is there a way that you have to try to identify people that can support these patients?
So I have met somebody here in the Boston area, and it was kind of word of mouth. I happened to be playing tennis with somebody who knew somebody who I got a hold of. But this was something that has been a gold mine for me. And it's a psychologist who studied chronic conditions in teens. And so about coming to learning, getting to acceptance. So it's really going through the phases of denial to coping, getting to coping. And one of my favorite things to see somebody do is actually volunteer at the courses that I teach. So going from complete denial to accepting the condition to giving back to the community of physical therapists, learning how to take care of other people who have their condition. So it's that full circle experience that is one of the most beautiful things that I get to experience.
I guess Kelly and Prachi, I'd throw that out to you guys too. I mean, I think some of the onus needs to be on the orthopedist as well, and we recognize it. And Amber, I know you really are involved in this as well, but I mean, obviously it's not every patient that has really significant issues that requires, I think, seeing a therapist, but but if you could maybe just briefly, I know we're kind of running short on time, we only have a couple minutes, and I want to answer the last couple of questions, but just other experiences you have with helping patients, get those resources.
We're just very fortunate here that we have access to the whole team, and I think that's always the hardest part. I think the big thing is if there's any variables that show up in the questionnaire, if they're showing signs of self-image or mental health, or when you give them the brace belief questionnaire and they're ticking off things that are more concerning about how they feel about themselves in the brace, things like that. Normally having a conversation with the parent. If there's a school counselor, that's the easiest route to go to versus more like a private therapist. And then maybe I'll shoot it out to Kelly, see if she has any other thoughts.
Yeah, thank you. That's great, Prachi. I think that, and Amy, amazing. I think that I've personally never been so invested in the patient population as I am with these teens and adolescents, like available whenever, weekends. I think and to be honest, for some of our patients, I use the analogy of the marathon. I'm a runner. The end of the marathon is surgery sometimes. And I think we've all had the privilege of walking patients through that surgical and post-surgical process. And I think like Amy said, as physios, we are the most frequent touch point for patients and within the team within this process. And I think we all take that responsibility and that privilege really seriously. That's not a very tangible answer, but
No, I know, but these are difficult problems. I do want to kind of, as we're winding up, just get to a couple of questions that were out there. There's several questions talking about function and return to activity after after surgery. If those that do progress to surgery, are they limited? Are they able to dance? Are they able to participate in activities? I think the short answer is yes. We've all seen this. Patients go back to high-level athletics and things like that. But I think from it'd be interesting to talk to from the physical therapy standpoint, who's seeing a lot of these patients post-operatively. Just to maybe discuss a little bit about their ability to return to their baseline activities after surgery. Maybe Amy, you can say a word or two about that.
I have a patient right now that is 5 weeks post-op, and she is against doctor's orders riding an ATV. She feels so good. She had a T2 to T12. And she is doing phenomenal. Painful couple weeks, the first 2 weeks, but doing great. And yeah, it is surprising how quickly they are able. I asked her if there was in-person school when she thought she'd be able to go back. And she said, sitting up for long durations of time was a problem. So she felt really happy that she had Zoom school right now so that she could take breaks and lay down and get up. So she thinks that she would just be now interested in going back to an upright position schooling thing at 6 weeks. And honestly, I felt like we were trying to hold her back more than anything at this point.
Yeah, I think we all have patients like that, which is always amazing. And I think just maybe one final question, which is a very interesting question, and I'm actually going to throw this to Jim, which is the question is, what is the success, or really what is considered a success after fusion surgery? So Jim, that's obviously kind of a little bit of a loaded question with a lot of possible answers, but I think it's a good question.
Unfortunately, I think a lot of surgeons view it as how the x-ray looks at the end of the case, or how the patient feels about their appearance, but it's the long-term outcome. So is the family able to, or is the patient able to live a good life? Are they able to have stable relationships? Are they able to hold a job in the end because their back is not interfering with them? That's what our goal is, and it's to prevent long-term arthritis. It's the long-term outcomes. It's not the 1 year. It's not the 5 year. It's really the long-term outcomes on those. And fortunately, what we're finding is that our treatments in that realm are really generally good. That includes the old treatments like Harrington rods. So in general, our outcomes are very good, but they are not short-term, and we can't judge our results based on 1 or 2 or even 5 years.
Yeah, no, I think.
And I'll just add on to that answer a little bit. And that answer is exactly the right answer. It's the answer that Dr. Sanders or Dr. Roy is going to give. But, many surgeons are admittedly too focused on radiographic endpoints and just seeing a perfect x-ray. And I think one of the things that is sometimes lost, and I hear this from my fellows all the time, is that we can often make the x-rays look great, but it's not in the best interest of patients. There's a trade-off in judgment and decision-making about how many levels to fuse. And there are times where a more selective fusion, a fusion that doesn't involve the lumbar spine, results in more residual curve and a lumbar curve that looks a little bit bigger. And the new surgeon, the fellow that's 1 year out into practice, doesn't want to show that. And, I love to show that, because I know that if we stay out of the lumbar spine in a kid, even if they have a 20 or 30 degree residual curve, in the long term, for all the things that Jim just mattered, for all the things that you heard the panelists speak on tonight, they're going to do great. So there are trade-offs. It's not about the x-rays. And that's why the power of this group of multidisciplinary collaboration of surgeons and physical therapists and psychologists and great orthotics people is really critically important to drive the best outcomes for these patients.
I agree. I think that's great. I think we're just about out of time. I'm not going to have time for that long-term outcomes talk. So, Michael, I don't know if you have any final parting words for us.
No, I want to thank everyone. I wish we could all be together. I really do. It's just getting a little bit old. But still, we had almost 200 people on the Zoom tonight coming in to listen to an amazing group of panelists. I want to thank everyone in the panel for spending time, putting talks together, spending a Thursday evening in our time zone anyway, making this all happen. And encourage you guys to follow up. We are all available, reachable. The world is flat. Our therapists are doing virtual Zoom therapy right now. I think we would be happy to connect with you in any way possible. So for now, I'm going to say thank you, good night, and wish everyone a great weekend. Take care.
Thanks, everybody. Have a great night.